Welcome, everyone, and thank you for joining us today. The AANS is accredited with the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all of its sponsored educational activities. In accordance with the ACCME standards for integrity, independence, and in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculties, and any other individuals in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed below. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not enlisted have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. Participants will receive an email notification of enrollment to claim credit. For any issues, questions regarding claiming credit, please contact education@aans.org. Now I'd like to introduce Dr. Hajipnias to get us started for the day.
Thank you, Tim. Thank you, everyone. Really excited to have this special webinar today on spinal oncology. Before we get started, I do want to thank the AANS for all its help in our webinar series with the tumor section. This has been a highlight for the tumor section. All these are recorded, so please visit our website, the tumor section website, which has been recently revamped. I'm really excited about this particular webinar focusing on spinal oncology and intramedullary spinal cord tumor management. I'd like to thank our spinal oncology co-chairs of the tumor section, Chris Newman and Pascal Zinn, for putting this together. They're going to introduce our featured speaker, who we just couldn't think of any other person to launch the oncology series, and Dr. Paul McCormick. So once again, thank you, everybody, and really looking forward to this webinar.
Well, thank you very much for the introduction, and I'll say thank you to everyone for joining us for the first session of the AANS CNS Tumor Section Spinal Oncology webinar series. As an overview, this series really aims to cover topics relevant to all surgeons who operate on tumors of the spine and the spinal cord. And over the course of this series, we're going to cover topics ranging from spinal metastatic disease to primary spine tumors to how to build a spine oncology practice, up to today's topic of intramedullary tumors. Each session is going to feature experts from the field sharing their insights and answering questions about the topics, and it's going to be moderated by members of the Spine Oncology Subcommittee from the tumor section. Today's moderators are going to be myself, Chris Newman, from Memorial Sloan Kettering Cancer Center, and Dr. Pascal Zinn from the University of Pittsburgh Medical Center. And our speaker today, as has been mentioned, is Professor Paul McCormick. Dr. McCormick is the Gallon Professor of Neurological Surgery at Columbia University and Director of the Ox Spine Hospital at the Neurological Institute of New York. He's an expert in the management of intramedullary tumors, having published and lectured on the subject extensively, in addition to his years of surgical experience. And words can't do enough, but I'll say, Dr. McCormick, thank you so much for being with us today, and I will hand it over to you to teach us a little bit about this topic.
Thanks so much, Chris, and thanks to Pascal, Tim, and Costas. This is really an honor for me to be asked and kind of give my experience over the years. Something I've learned the hard way in this video. As I say, I'm happy to discuss anything in greater detail, but I'm just going to kind of give you the 10,000-foot view on some of my experience, some of the things that I've learned. And with that, I'll get started. Let me see if I can share my screen. And I think this is it. Are we good there?
Looks good.
Somebody in the Q&A says there is a lot of echo in the background, so I think we all mute probably best, and then only the person who speaks actually unmutes. And then there's a Q&A box where listeners can put in content.
Okay, great. Can everybody hear me okay? That's clear? Okay, great. So I've been asked to talk about management strategies and techniques for intramedullary spinal cord tumors. I have no disclosures. Here you see that, they're fairly rare, these tumors, but heterogeneous. There's a lot of them. There's a lot of complication to them in terms of, how we deal with them surgically and in terms of decision-making and what have you. But you have the ependymomas, the most common. Obviously, they start in the central part of the spinal canal. Astrocytomas, also fairly benign. And then you have these kind of kind of astrocytomas that are partway between ependymomas and astrocytomas, the subependymal, the pilocytic astrocytomas. Hemangioblastomas account for about 10% of tumors, and they arise from the pia in most cases. And then you have some unusual kind of intramedullary, extramedullary, or some element of both in terms of dermoids, lipomas, and melanocytomas, both benign and malignant with respect to the melanocytomas. But they have a lot of things in common. Almost all of them are benign and slow growing. Unlike intracranial tumors, they rarely exhibit progressive anaplasia. And so surgery is the only or the primary treatment options for the vast number of patients with intramedullary tumors. So it's important to optimize both selection techniques and kind of how we take them out in terms of trying to reach the optimum outcome for these patients. So there's a couple of issues that have evolved over time in terms of diagnosis and management before we even get into the operating room. And one of the most important ones has been the sensitivity of and access to diagnostic imaging, and particularly MRI. It's given us earlier diagnosis, which is good, but it also identifies us a lot of incidental or asymptomatic lesions, which create a real dilemma in terms of recommendation or follow-up for these patients over time. So on the positive side, it gives us very precise localization, characterization, earlier diagnosis. They're at a smaller size. There's lesser edema. The patients are at a higher level of function. So all those things reduce the risk of intervention. On the other hand, we're seeing incidental tumors to a greater degree. And here's a patient that I've been following over the last few years. We know that they're biologically indolent. You cannot make a normal patient any better with your intervention. So any benefit you have would be a prophylactic one, except there's risk to this surgery. Almost everyone after this surgery will have some degree of posterior column deficit that they didn't have prior to the surgery. So there's a cost to it. So with these in mind, with these kind of conflicts in mind, you have to conclude that patients rarely get better after surgery. Preoperative deficits will remain in addition to new proprioceptive deficits that they have from your surgery. And the postoperative function is best correlated with preoperative function. The better you are coming in, the better you are coming out. And so usually I don't recommend surgery for incidental tumors, but as soon as a tumor becomes symptomatic, and if it's just hyperreflexic, maybe some mild sensory or intermittent balance issues, that's the point where I recommend that surgical intervention be done. So that's kind of my view on the selection of patients. The other side of the coin is the sensitivity is great, but it sometimes outdoes the specificity. And so often we're in a situation where we don't know what the abnormal signal that we see is on the MRI. And it can look like a tumor, but we're seeing a lot more things. And we're either being asked to operate from a therapeutic standpoint or from a diagnostic. We want tissue. And so it can be difficult to differentiate medical myelopathies. For example, you see on the image to the right, multiple sclerosis in this particular case, but also transverse myelitis, sarcoidosis, tumefactive multiple sclerosis, where there's actually some expansion of the spinal cord in a patient who has kind of subacute presentation and progression. So it can create some issues with patient selection. I rarely do spinal cord biopsy. The reason is that you can usually distinguish a surgical case, if you will, from a medical one. Acute onset, substantial deficit with little or no cord expansion in an eccentric lesion, as we saw with the multiple sclerosis previous patient, almost always tells you that that's an acute medical demyelinating or inflammatory process. that you have no role in, either diagnostically or therapeutic. And when you do a biopsy, what you're going to find is the same in every patient. What you see to your right here, nonspecific inflammation. You got a lot of perivascular white blood cells that don't give a specific diagnosis or direct your treatment. So be careful about doing biopsies in these particular cases, because you rarely get any useful information, but you do cause risk to the patient. Other condition, extrinsic myelopathy, spinal cord compression. You see that intramedullary signal abnormality. To an unexperienced person, that might look like a primary tumor or something in the spinal cord. But this was, caused from cervical spondylosis, very common. Common things are common, and it actually got better after just a, straightforward ACDF, both clinically and radiographically. Things that are in our purview, but maybe at a distance. Here you see a Chiari malformation, and this looks almost like a tumor, where there's a solid expansion at about the C6 level, and above it and below it there are cysts. And so again, you have to see what you look for and rule out other issues. So with that behind us, let's talk about the actual tumors that arise from the spinal cord. The vast majority are glial, and the vast majority of them are ependymomas. We do see astrocytomas, and then we see this middle of the road subependymomas, pilocytic astrocytomas, gangliocytomas. They're all benign, and most of them, even the astrocytomas, have a fairly good margin. They tend not to infiltrate, unlike what we see in the brain. So these are often treated and have the same outcomes as the ependymomas do. Hemangioblastomas about 5 to 10%. And then we get down to the rare ones: inclusion tumors and cysts, dermoids, epidermoids, lymphomas. We're not going to really talk about those today. Cavernous malformations, obviously they're not a tumor, but they can act like one. And again, we're not going to talk about them today. Metastatic tumors are actually really rare in the spinal cord. Almost never see them. Pediatric, the only difference really is we see some of these, inclusion tumors and cysts. Astrocytomas tend to be more common than ependymomas. Pilocytic subtypes are very, very common. Inclusion tumors, neuroenteric cyst, those types of things. And spinal stability obviously is an issue, but we're not going to talk about that today. So most of what the focus is going to be on are ependymomas and the surgical techniques for intramedullary glial tumors. As I say, they represent about 80% of intramedullary tumors in adults, overwhelmingly histologically benign. I think I've maybe seen one or two in my entire career. They do not have a capsule, but they are non-infiltrative at the spinal cord tumor interface, and that's what we're trying to develop. That's the focus, and that's the endpoint of our surgical intent, and what everything is focused on is to develop that plane if we safely can. And surgery is the primary treatment option. We're front row here as surgeons. These are not responsive to chemotherapy. Obviously, very limited response to radiation treatment. That's it. We have a first line treatment, so you want to optimize it. You want to make sure that you address every issue, both in techniques, in strategies, and in selection criteria for these patients to optimize that outcome, because we're all they got. So with that in mind, I'm just going to kind of go through the workflow of this, the things that some of them I've learned the hard way, in terms of just your checkbox in your brain that you have to think about. Things like positioning, adequate exposure, securing the operative field. You're going to spend a lot of hours taking these things out, so you want an optimal environment for that. You need appropriate access to the tumor. You have to open the spinal cord to get at the tumor, to be able to take it out. So you need, in most cases, a midline myelotomy. You have to expose the dorsal and polar margins of it, both from the dorsal aspect of the tumor and go all the way up to the rostral and the caudal polar margins. If they have a cyst, that makes your life a little bit easier. If they don't, but you still have to go beyond them. We use peel traction sutures, which is simple, but they really help us with giving us counter traction against the spinal cord so we can develop the margin. And you have to have the approach assumption that you're going to take these out. You can't say if it has a margin. So I'm just going to do a tiny little myelotomy. And if I see a margin, I'll take a biopsy. And if it says ependymoma, I'll continue. Well, the problem with that is that you're not always going to see a direct, well-defined margin on a little tiny opening. And we rarely get a precise diagnosis with an intraoperative biopsy. They'll either say it's consistent with a glial neoplasm. Well, that doesn't really help us. Or often they give you no information whatsoever with it. And they certainly are not as precise as they will be 2 weeks after. So you always have to have a mindset. You know, we're here for the long haul. We're here. And so we need an adequate exposure to look at this to identify what the strategies and techniques will be to remove it. You then have to define, dissect, develop the tumor spinal cord interface. And so that's usually, and you'll see that in videos and images, traction on the tumor, counter traction on the spinal cord, isolate, cauterize, and divide fibrous adhesions and vessels, and then internal decompression is needed. And you just, repeat, throughout the procedure for that. And you'll see that in some of the videos here. So positioning, little detail, it's important. I like to have the tumor as parallel to the floor as possible. You're working under high magnification. You want things in the same plane, so to speak. And so, have to think three-dimensionally, and you want to have a stable axis there. So I like to have these patients, parallel to the floor. The tumor should be parallel to the floor if at all possible. Your exposure. Everybody hears about the Russian nesting dolls. You have a skin incision that's this long and certainly long enough, but then the muscle dissection is a little lower, the bone is a little bit less, the dura is a little bit less, and so all of a sudden, before you know it, you don't have enough access, rostrally or caudally, even laterally, and you have to. You are sabotaging yourself if you don't have that. I have to be in it. You have to, have the exposure that you need to take out the tumor. Otherwise, you're walking uphill the whole day. And so here's how I look at after I have the exposure done, whether it's laminoplasty or laminectomy, I want to know that I'm above the tumor. I want to know I'm below the tumor, and a bit below it, so that I can open down into hopefully there's a cyst, but if there's not, and often these tumors they thin as you get into the polar margins of them. And so there's more spinal cord that you have to go through to get to the tip of the tumor. And a lot of us are, we don't want to do that, but you have to be committed to that. You have to go up there and make sure that you're beyond it by, a millimeter to at least, as you see in these ultrasounds. And you have to be on the lateral aspect of the tumor as well. Otherwise, you put yourself at a disadvantage. So here's one we did a number of years ago. Again, you have to have the adequate exposure. You have to have the hemostasis. You are in the most dependent portion of your surgical field. And so blood wants to come down, CSF wants to come down, things want to get in your way, gravity goes down. So you need to have hemostasis. You need to have a secure. So it's not just long enough in terms of your exposure, but it has to be, as I say, it has to be dry. And so you have to be meticulous on this because where you're at. So in the vast majority of patients, we do a posterior midline myelotomy. Very rarely we're going to go outside of that. And I'm not really going to talk about that. It's a median septum. It's not a fissure. You're going to have to open the spinal cord. The pia is very robust in the spinal cord. It's not like the brain. And so you have to cut through it and get it. But that's usually what we take. So here's the midline myelotomy. Again, you want to be right in the midline. You can see the dorsal root entry zones on either side. You can kind of, look and see where the midline is. Usually there's a vascular presence that you can see and identify. I'll show you that in the video. That's not very difficult to identify and get down. And what you want to do is you want to get down to the dorsal aspect of the tumor. And as I said, you need to get past the cyst if you have, but you don't have to uncover the cyst. Here's the one with a big cyst, going up from the, cervico-thoracic junction. I'm sorry, the cranial cervical junction. Tumor doesn't even start till C7. And then you have, and here's it goes to T2. And then below that, you have big cysts. And you can see on the postoperative imaging, we didn't need to do anything up here where the cyst is. Cyst is now gone. But you do have to open a little bit up to the C7 level to make sure that you know that you can get into this here and you can drain the cyst. So you don't need to open up over the cysts. But a number of these tumor have an enhancing polar cyst, and in those cases you do have to go because there's tumor up here. You know, these are polar cysts, but they enhance. And so if you don't take these out, these patients are going to have a total resection, and you're going to be back in possibly 2 years or maybe less than that. So in those cases, and as you'll see here, you know, we did laminoplasty all the way up, you know, to the C3 level to where the cyst was, so that we could take this the cyst, the enhancing cyst, out as part of resection of the tumor. So here you see, and you can follow the midline down. You usually have these vertical vessels that you can see on either side of the spinal hemichord that pretty much tells you that you've, you know, maintain your midline location, and you want to, you know, kind of not only get to the dorsal aspect of the tumor, but you want to go rostral and caudal to make sure that you get just beyond the rostral and caudal tumor hole. If you have a nice responsive tumor that has a good, reliable, kind of capsule to it, or is not really loose and bloody, you can take it out as one piece and roll it out as we did in this case, and that's kind of the idea. But most of them aren't like that, unfortunately, and so you have to do it piecemeal, and you have to have a strategy to do this. Here's a video I'm going to show. Now, this patient had a rostral and caudal cyst, making our life a lot easier. And here you see the post imaging on it after we've taken the tumor out. And I'll show you the video now. Here it is. Here's the midline. And you can see blood vessels coming out of it, draining veins. Cauterize this, go rostral caudal, staying in the midline. Use, a beaver blade to open the midline, and then traction, counter traction to get down to the tumor surface. And then you go laterally a bit on the tumor surface. And then here I use these clipped in peel sutures, 6-O-proline, to give me some counter traction. Then you have traction on the tumor, counter traction on the tumor, cauterize, divide, feeding vessels and fibrous adhesions, finding the polar surface. Here's the cyst being drained, and makes our life a lot easier. Cautery on the tumor, and then we can increase even more retraction of the cord, internal decompression, because it's kind of fat. And then again, traction on the tumor, counter traction on the spinal cord, fibrous attachments, feeding vessels, cauterize, divide, and here you are. You have this outcome. Now you say, well, that's nice, but that's a small tumor. It had cysts on either side of it. Shows something we don't know. So here's a more difficult one. This is high cervical. It's an ependymoma. It's a really large girth. It was extremely vascular, very friable, and really not any polar cyst. Maybe a little bit inferiorly here, but for all intents and purposes, this was solid here. But it's the same strategy. You may do it in different ways. It's like building a sculpturing. Where you have a big piece of rock and you have to identify some picture within it, some form within it. And that's what surgery does. You'll see we just progressively go forward at different areas of it and doing different things at different areas until it all comes together. And I didn't have a video of this; it was too long. But what I do is I have a bunch of pictures, starting from upper left, then going to the right, and then down. So here's the dural opening. You see, everted dura. Tap down or tie down, very dry, very secure environment for us. We're now opening, here's rostral to your left, caudal to your right, down here. We want to release the arachnoid on it, which I've done here. And now, again, you can see where the midline is. And you do, make sure you do a myelotomy all the way over the rostral caudal extent of the tumor and a little past that. Again, you don't want to be walking uphill. You don't want to be working from a disadvantage. And so, oops, can I not get this? Yeah, so now we want to deepen. Again, micro dissector, in one hand, micro forceps in the other, just spread, and then, go a little bit deeper with your dissector. You want to go to, here's the end of the tumor right here. We can see well, it's not the end of it, but we can see the dorsal aspect of it. And so now we extend rostral and caudal to identify the entire rostral caudal portion of the tumor. Here's the inferior margin here. And now we're just getting past, you can see where this cotinoid is, the inferior margin of the tumor. Now we want to go to the superior margin and make sure we're up high enough and down low enough. Then we put the peel traction sutures in here. You can see this tied to the pia and then clipped to the dura. And it gives us some lateral traction on the spinal cord. You can see the midline myelotomy right there. We've made it a little bit deeper. So I've chosen to work at the inferior pole. I want to get around it. I want to start marginalizing, finding out where it is, figuring out what its 3 dimensions are. And so now we're trying to work on dividing the margin, the inferior margin of the tumor, and kind of coming around to its lateral margin there. Again, doing more on that. More still, you can see us now pulling it out from there. Now we want to deepen it a little bit on both sides. Here it's on the left side, cauterize, cut, divide these feeding vessels, these attachments. Here's more superiorly, more inferiorly. And now we're trying to connecting that to the inferior margin of it that we've already worked on. Again, sculpting it, if you know what I mean, trying to get an idea on it and using the tumor's own girth against it. This is a very vascular tumor, as you can see. It was kind of friable, but if you leave it in a big period or a big size and you make a big or a deep grab with your forceps, your tumor forceps, you know, you can have enough traction on the spinal cord that gives you enough counter traction, and so you can identify the margins of the tumor, cauterizing, dividing these feeding vessels. Now we're seeing us coming around the margin of it, the inferior margin, and exposing part of the distal lateral margins of the tumor to begin to get an idea of what the 3 dimensions of this are. Again, more inferiorly, you can see we're rolling it up, and now we're coming and beginning to take the tumor out of the actual tumor section here. We're working now on the right side of the lateral margin of it. And at some point, this tumor, as you saw, it's just too big to take it out. And so, you know, what we'll do is we'll, you know, cut out a part of it. We'll use the ultrasonic aspirator to kind of debulk the central part of it so we can see, so we can still work around it through the operative exposure that we have. And here you can see after we've shaved it down, we have a nice resection here. Now we've gone laterally here and inferiorly to start to, you know, again, pull up on the tumor itself, you know, use its own girth against it, and see this, define it, see it, and to be able to dissect the margin between the tumor and the spinal cord. And then here again, internal decompression, more as we get more and more of the tumor loose. We're now working on the superior margin of it, pulling it out, and inferiorly out of the tumor cavity. Here again is now a large piece of the rostral tumor pole. We're pulling it out. It's actually out of the surgical area. We're working on the ventral side here. Again, a little bit more inner, kind of inner tumor resection, and now making it smaller and smaller, working and coming toward the ventral aspect of the ventral aspect's the most difficult side because you can't really have counter traction on it. You're working perpendicular to the tumor attachment from where you are, and a lot of the vessels are coming through there, some of them coming off the anterior spinal artery. So you want to kind of work around it, have as much 3 dimensions as you can to get it out. And here you see we're working on it from the side, from the top, from the bottom, moving our space so we know exactly where that tumor is as we do the very final part of the tumor. Again, same thing. And then finally, the last piece here. Again, you want to leave a little piece of bulk there so you can pull on it. And now you can see that you have a complete resection in this particular case. Look at this patient. It's complete resection. Okay, he's a little bit unsteady on his feet, but he's walking tandem. And he has some posterior column deficits, but that's pretty good. And that's the expectation in these patients if you get them early enough at a high enough level of function. Here we did a laminoplasty only up to the T2 level. Obviously, we had to do even a suboccipital craniectomy partially to get adequate exposure. If you don't have it, if you cheat on it, you're not going to have the safe exposure. But that's a pretty good outcome for this type of a tumor. So with those strategies, with those endpoints in mind, with those thought processes and techniques, it doesn't matter that you can be entirely cervical. In this case, on your left, this is a pilocytic astrocytoma, completely resected on the right side. And this patient is ambulatory. This patient, even going up to cervical medullary, as long as you come down at it at the midline, get onto the surface, stay on the tumor, gentle traction and countertraction, internal decompression as you need to it, you have these results, even if they extend up into the lowered brainstem. Now, the reality changes sometimes. Sometimes the tumor is not dorsal, or it's ventrolateral, and you can use other options. This tended to be an astrocytoma, and it was right on the front, peel, attachment to it. So we came from the front on this. Again, same concept, same idea. Stay on the tumor surface, traction, countertraction, and here you see start and finish right here. We obviously have to fuse it, and here's the postoperative. This is about 12 years ago. And this is actually recent MRI, didn't grow back. It was a, pilocytic astrocytoma, cavernous malformation, again, large tumor, or mass. We approach this through a far lateral approach. And sometimes when tumors come to the surface, you can use that, particularly if they're easy to dissect, like cavernous malformations are. And so we did a far lateral approach. You can see a little postoperative, fluid right here. Take that out. Minimally invasive approaches for small ventral hemangioblastomas in this case. I mean, so you can change your strategies, you can change your approaches to this depending upon the particular area and the advances that have been made with spinal surgery over the last few decades. I'll move lastly to the hemangioblastoma because they're different. They're not so much intramedullary as juxtamedullary. They arise from the pia. Almost all of them have a surface presentation. 75% gratefully are dorsal or dorsolateral, with a fair degree of kind of iceberg effect where there can be some intramedullary dissection. But here you can see a pathology autopsy. Actually, almost all of them arise and have a dorsolateral or dorsal presentation, as you can see here. The problem with them is they're very vascular, so internal decompression is not an option in these folks. But the strategy here is different. What you do is you deconnect them circumferentially. You may leave one of these vessels intact until the end, but at the normal peel spinal tumor, it's a kind of like a sunset orange color. You define that, you cauterize that, you devascularize it, and then you just come around it right there and take it out as one piece. And for the vast majority of them, it actually, it makes your life so much easier when they have a dorsolateral surface presentation, as most of them do. And you can do this with them because you really can't do internal decompression, but that's the key to that. This is their weak spot. This is how you deal with it. I'm going to show you a ventral intramedullary one because it shows, I think, that point, but also that we can be now in this day and age different and innovative in our approaches to this. And there's no way I would do this from the back because I don't have access to the peel origin of it. So I can't control the bleeding. And I don't want to go through the entire spinal cord to get to this little tiny tumor. So we can do this from the front. Here it is. We've done a 2-level corpectomy. Here you see the sunset orange appearance. And we just want to cauterize the peel tumor margin interface, detach it, and we can remove it as a single piece, as you see here. It'd be the same if it was dorsolateral, but they're very, very straightforward in most cases. And if you understand that strategy, if you understand that anatomy, your life is a lot easier, and you can deal with these things without very much concern in terms of bleeding or having access to it. And here's the postoperative X-rays here. Again, patient has a fusion. They need to be in a collar for a period of time, but they do very well. And here's the postoperative image 3 months after the surgery. And this patient obviously did great. So I'm going to end it there. And I wanted to, it's fairly simple. It's very straightforward in some ways. But there are techniques, there are a little bit of tricks here, but some patterns and some lessons that I've learned the hard way that have been very helpful in, from my perspective. And I hope they've been, very helpful for you. And I'm happy. First of all, thank you for letting me present this data, and I'm happy to take any questions.
Absolutely great talk, Dr. McCormick. We're thrilled to have you, and this body of work is just incredible. I'm also doing a lot of those surgery myself. I learned a lot, and it was very, very interesting for me to see how you do things. And I have a few questions on technique and blood pressure management also. I just wanted to get it started with neuromonitoring in terms of what are you monitoring? SSEPs, MEPs, dorsal column mapping, D-wave, and there's all these kinds of things. I know the surgical acumen and technique is the most important by far, but I'm interested how you manage that, and then if there's changes in neuromonitoring, how you respond to that.
Yeah, that's a great question. And I might be a little bit old school on this. I don't rely very much on intraoperative monitoring. I do it. You can't not do it. But how much information does it give me? Oh, very, very little. The information it can give you is important. So, you hope you don't need it. So you almost always get some drop off in SSEPs either during or shortly after you've done the midline myelotomy. I don't use mapping because, to map it all the way up, at each millimeter along it, I think is not particularly practical. And I think in most cases you know where the midline is. You can see the vessels coming out of it. You see the dorsal root entry zone. And so I don't know that it's that precise. And by virtue of the fact that you're opening the posterior column, you're going to have some deficit. So I don't use that, particularly very much. Blood pressure is a good point. I mean, you don't want it low, obviously, but you don't want it high either. And so if I do get a drop off in my somatosensories, I'll ask for a motor. And if that, concurs, then I'll look at what the blood pressure is. I'll stop for a while. It has to relate to what I'm doing too. If I'm operating or putting some tension or counter traction on the spinal cord, there needs to be some correlations with it, because I will tell you, on the other side of the coin, there's a lot of times where there are false positives with SSEPs and motor evoked potentials. And I think there's probably a lot of spinal cord tumors that have been left in place because of those false positives. And so it's a tool, but it's not a treatment. So you have to have a certain balance with it. I know I'm biased. I don't rely on it that much, but it's a safety net, you bet. And I'm never not going to use them. And maybe there are people who have different experiences. I'm delighted and happy to hear from them. But you don't want to get it to a point where you have to respond to changes in the SSEPs and the motors. And we actually, other than the myelotomy, we rarely get changes.
Yeah, it's an interesting question. I often use a dorsal column mapper, but then ultimately either I confirm what I already knew if it works, and if the technique often doesn't work that accurately, then I'm proceeding anyway. And the surgical information, like texture, like visually tactile feedback, is basically the game. It's much more important in my opinion than relying on neuromonitoring. D-wave electrodes above and below sometimes is another reassurance. Independent of the depth of anesthesia, I found that the motors are going to be okay.
Yeah.
So that's maybe just for my own blood pressure during the case, but it may not be ultimately that helpful.
There definitely is something reassuring about when your motors get to fluctuate, or there is that issue, but the D waves still are present. That does kind of, at least for me as well, kind of gives me that sense of taking a breath of like proceed, like you haven't done something catastrophic. I did want to ask a question from the actual audience for Dr. McCormick. The question arose of how do you balance the decision between kind of observation versus intervention in someone who's clinically asymptomatic, but with an imaging finding where the tumor looks like it's growing on serial images?
Yeah. Yeah, that's a great question. And do you involve patient preferences in those sorts of issues? Um, I think you take it kind of case by case, and you're right. I didn't talk about that, but there are some times where you do see growth, and you extrapolate it forward and saying, look at this rate. And I look at it through the lens of some of the tumors that are really tiny. They're actually harder to take out because you have to distract so much more. When the tumor is larger, it's done a lot of the distraction for you. And so I look at the really small ones, and I'll accept a certain amount of growth to it. But if it gets to a certain part where you say, you know what, if it continues to get bigger, and we know it's going to, that's going to make my life a little bit more challenging to take this out safely. So that's a circumstance where I say, once its size works against itself, in that it goes from difficult to easier and then to harder again. As it's starting to get to harder, I might say, you know what, it may be time to do this. We've already had the proof of concept that it is growing. We kind of get a sense of its biology, of the rate it's growing. Why do we want to wait until you have a deficit? So that's one issue. The other issue is if they have some edema with it, or that develops, that's another point where I might say, you know what, the spinal cord is becoming less tolerant of this, and the risk of manipulation and countertraction may be going up like that. So it's not a perfect world, but that's a great question in terms of it's hard to know when the exact time is, but those are considerations, and you involve patients also in that kind of a conversation as well. But thanks for asking that question, because I did not touch on that.
I think one more just from the group, we kind of in a similar vein, we kind of talking about the patient and the experience and involving them in this. One of the participants asked the question of how do you really, focus on counseling patients about post-op deficit, but then also kind of from my own side, how do you talk to them about the expected recovery course of what it looks like a week out, a month out, 6 months out?
Yeah, these are the longest consultations that you have, because you want to explain that issue. And what I say to the patient, very, very clearly, at least I hope, is there's a cost that comes to this along with this, and the cost at least is going to be some posterior column deficit, and you're going to have it, and it's going to mean that you might feel pinprick and temperature, but you're not going to feel vibration, light touch. You're not going to know where your toes are, maybe even your hands, early on. And I'm just telling you that. And the reason I tell them that is because virtually nearly every patient after the surgery, you say, how are you doing? Can you move your arms? Can you move your legs? And they do. And they say, hey, doc, I'm numb. I'm numb in my legs. I'm lung in my feet. I said, remember we talked about that? No. I'm really numb. And, it's theory and reality are two separate constructs, and so I spend a lot of time talking to them about that. But again, it's theory. So anyway, I'll still spend a lot of time talking to them about that. But they do, and they tend to get better over time. And you saw that one patient he was numb after the surgery, but he wasn't bad at tandem gait. And he said, yeah, but my legs are numb. But he could do it. So it's not that functionally impairing. The balance is pretty decent. You use your eyes maybe a little more. You walk a little bit heavier. But they are very functional. But you got to talk to them about that. The other issue of if they have existing deficit, those deficits almost never get better. Sometimes they do in the hemangioblastoma patients if they have a big cyst and the cyst is causing the symptoms. If their symptoms have been short term, they can get better to some degree, but the longer they've had a sign, a neurologic deficit, and the more significant that deficit is, the less likely that they're going to show any improvement. Now, there is room for improvement with practice, like shooting a basketball, and that improvement and some neurologic improvement in terms of strength, maybe sensation, can occur. But I've seen it up to maybe 18 months, but no longer than that. And most of them that they do get it will be within the first 4 to 6 months after the surgery.
Thank you so much for that. There's another question, a follow-up question to one of my questions on blood pressure from the audience. And do you manage those cases like in a spinal cord injury protocol where you increase the MAPS post-op perhaps to over 85 is the question?
I never have. Either in the operating room or after. I mean, we have a rule, not low. We don't want it below a certain amount that would be considered. But I don't use higher blood pressure for to make sure that maybe some of the marginal areas don't get ischemic. I've just not seen a postoperative demine, or getting worse in that regard. I just want them at normal pressure. And I have not seen any data or research to suggest that there is a benefit. And to me, everything is about avoid risk. Don't hurt the patient, avoid risk. And to me, I see a risk with, having higher blood pressure. Because if you're trying to push it up, you may go a little too high, and then you're back with an epidural hematoma or subdural hematoma, particularly with some of these vascular ones.
Absolutely. I think, yeah, less intervention is more, and being overly aggressive can indeed harm the patient. Yeah. There's another question from the audience. After a gross total resection, how many weeks do you go for a repeat MRI, or how long do you follow a patient? Obviously, depends on the different pathologies, but perhaps you can just in general focus on your kind of follow-up MRI strategy and
Yeah,
how long do you follow the patients in general?
Yeah, I think it can depend on a couple of issues. I mean, if you have a gross total resection and you know it, maybe 8 weeks, because you want the smoke to clear a little bit. You want any, hematoma, swelling, edema. You want to have a clear new index baseline. And for me, 8 weeks, 3 months, to say here's the new you. I think that's important. I think if you're like if the tumor is kind of irregular or something and you're not sure about, did I get that nodule out? I'm not sure, or maybe I was concerned about harming the patient. You might get one early to kind of proof of, did I get this all out? Because if your next step, if your management, if you might actually consider going back to the OR, could be impacted by that data, by that information, then you need to get it. And so most of the time that's not the case. And so, I'll wait till 6 or 8 weeks. But again, every now and again, I've had that situation, usually with cavernous malformations, but sometimes with these, where I'll get one early and say, did I miss something? And if I think I did, and we can go back and safely do it, then I'll say, well, let's do it now. I mean, you've just had the surgery. It'll not be easier than it is now. And then typically, if I have a clear resection, both in my mind, but also on the MRI, probably annually for about 3 years, and then maybe every other year for a few cycles, and then just, it was nice to know you, and they don't need it anymore. I mean, these almost never recur. And the hardest ones are where you have a little maybe nodule or enhancement, on the postoperative imaging, and you got to follow that. I've seen those more likely disappear over time than grow over time, but they can grow, and you have to keep an eye on them. And I would say I've taken maybe 3% of patients, maybe 5% over my career back at some point, sometimes a decade or two, sometimes, 3 or 4 years. And so it varies according to the particular circumstances.
I wanted to ask a question that I think comes up sometimes. You kind of alluded to with that whole, as you're building your comfort level with taking these tumors out, you might want to get that MRI early and things like that to kind of show that what you think you did is what you actually did. What advice would you have for people who are early career, starting out, just starting to do this, in terms of how to do these safely and to make sure that, what you think you've done is what you've really done? Any comments on that?
Yeah. Two things. The best surgeons I've ever trained are the ones who weren't afraid to make a mistake. They push the envelope, maybe sometimes too far, but they're gonna find out what they're capable of, and sometimes there's going to be a cost to that. And I'm a little different than that, in the sense that my first goal is do no harm. My second one is to take the tumor out. But as you go through your career, you realize that the tolerance for the spinal cord is more than we give credit for it. I mean, I'm not saying, be reckless, but it took me a while to figure out where that margin was. And I know I'm a more aggressive surgeon today than I was when I first started, because I learned sometimes the hard way by going over the line, if you will. And I don't think I've gone over the line very much, but what I have learned over time, as I say, is that, and that's why I wanted to show it on the video and on the pictures. And it's more about the mistakes we make mentally and from a technical standpoint. We don't, the opening's not long enough. The exposure isn't secure. You're dealing with bleeding. You didn't go past the margins. You didn't use, peel traction sutures. You didn't use traction countertraction. You weren't, willing to stay there for 6 or 8 hours. I mean, if you do those right things, and you're committed and consistent with them and disciplined, you get past those other issues, and you figure out what is the tolerance of that spinal cord, and so again, I think there's no substitute for practice. But I think if I knew earlier what that I know now, as I say, I think I would be much more confident saying I can get this out, and I'm the only reasonable chance that this patient has to go through his or her life with this thing gone. But I'm also a risk to that same patient, and so that's the needle you want to thread, and just have confidence in yourself. We're good at this. I work with orthopedic surgeons. They're not good at this. I mean, they don't do this stuff, but when there's a CSF leak in the room next door, who do you think gets called? We do, because we understand that level. That's what we do. We are brain surgeons. We are spinal cord surgeons. So that takes a little bit more, confidence, technical issues, but knowing what the endpoint is supposed to be, and focusing and optimizing every step in the journey from the start, patient selection to positioning to exposure, et cetera. Everything has to be a means to that end. And once you do it and you're disciplined enough to, kind of employ it, then the rest is just, doing it.
Yeah, that's very, very good advice. I know this will come up anyway, so I'm asking it. Can you comment very briefly, perhaps, on performing a instrumented fusion after those cases, or concurrent? You show cases with laminoplasties, but do you ever, if it's a much longer laminectomy case, do you at the same time fuse, or do you wait?
Yeah, I don't think I've ever, well, I have fused, but not at the time of the index surgery. I mean, we have carbon fiber now, which kind of allows us to image these folks after the surgery. So I think if there was some reason that you had to, or you needed to, I mean, maybe you do a costotransversectomy because you have a ventrolateral hemangioblastoma, or something like that, where you have to go lateral, or maybe, and I've had patients where I've done wide laminectomies and they've developed postoperative kyphosis, not very many, but and that number has gone down with laminoplasties, by the way. They absolutely work in the cervical spine. Not so clear about the thoracic, and not so clear about the lumbar. So I'll do that. But I've had patients who have had kyphosis, and I've had to go back to fusing them. But I don't know that I've ever done it primarily for an intramedullary tumor, other than the one-off situation where you have a very eccentric or ventrolateral tumor, where you have no choice but to take the facet off. Then I will, but I'll use carbon fiber.
That's great. Yeah, instrumentation also really prevents the MRI from working, essentially, and diminishes the value of follow-up entirely. Yeah. I think we can wrap it up here, probably. Dr. McCormick, thank you so much for this very insightful talk on behalf of the AANS tumor section. This was incredible to have you. And thanks to all the listeners and questions. This was very interactive in the chat here. So I really appreciate that. Chris, anything?
No, I think it's just great talk, great kind of sharing your experience, and like a journey of where you started, what you've gotten to, and what you've achieved. It's remarkable. And just thank you for taking the time to share with all of us today. It's been wonderful.
My pleasure. Thank you guys so much for having me.
Excellent. So we're turning it back to Tim Edwards for CME credit claiming.
Thank you to all of our faculty for a great webinar. Thank you everyone for joining us. I will leave the credit claiming instructions on the screen for just a few minutes in case anybody missed it. I will be registering all of the participants in our LMS, so credit claiming will be available by Monday. And thank you, and everyone have a nice day.
Okay,
Thank you, everyone.
thanks.